Hello, everybody. Welcome back to our series of podcasts called Menninger Mindscape. I'm Dr. John Oldham, professor of psychiatry at Baylor College of Medicine. It's been my privilege to host this series of podcasts. We've had some great guests with some very interesting information, and that's exactly what we're about to hear today. Today we're going to be visited by Dr. Alan Schatzberg, who's an old friend, and we're delighted to have you. Hi, Alan.
Hello, John. Glad to be here.
Good, great. Let me tell you just a word about Dr. Schatzberg. I can't say very much. He's here, by the way, as one of our speakers for our third annual national symposium that Menninger sponsors tomorrow. And this year it's entitled Emotion Regulation and Dysregulation. And we're delighted that Alan can join us. Alan, for about 10 years, was professor and chairman of the Department of Psychiatry at Stanford. And in 2010, I think it was, he rotated off that position and is now director of the Stanford Mood Disorders Program and very busy as a wonderfully leading researcher. Alan and I have crossed paths in lots of ways, and he's a former president of the American Psychiatric Association, but other things too, such as the American College of Neuropsychopharmacology, ACNP, which if you don't know is a big deal, and also of the Society for Biological Psychiatry. And I could go on, but I won't. We want to talk about other things. So, Alan, we were talking before, and I thought would be really interesting. What Alan's going to be doing tomorrow is joining me and Sue Hardesty and John Allen as a panel to talk about a very complex case and think about how to manage this case, combining psychotherapy and pharmacotherapy. But one other thing that Alan has done is serve as a senior editor of probably the definitive major textbook on psychopharmacology. And that's in its, 7th edition? Or?
Well, the manual is in its 8th, and the textbook is about to come out in its 5th. So we've been very pleased and very fortunate to be able to do that.
Yeah, and that's been a hugely important contribution to the field.
Thank you.
This guy's a psychopharm expert. So one of the things we were talking about was the state of the world in terms of new medications, and that's complicated. And you've been very involved as a kind of a lobbyist and an advocate to try to figure out a way to get the motor started again, to get some important new drugs developed, but that's not easy. Talk to us a little bit about that.
Well, what's happened over the last 5 to 10 years, John, is that we've seen a decrease in the total number of dollars invested in drugs for psychiatric disorders. Largely because we've had a number of failures in clinical trials that have not led to approval by the FDA. And in spite of the studies being done by good companies and with some interesting mechanism of action, they have often fallen short. And what that has led to is a kind of a shifting of investment away from psychiatry towards other fields. And some companies, some large pharmaceutical companies, have gotten out of the business entirely. They've not out of the drug development business, but out of developing drugs for psychiatry. It turns out to be easier, believe it or not, to develop drugs for cancer. It's easier to develop drugs.
That must surprise people.
For heart disease. Yeah. For psychiatry, it's much trickier. And why is it trickier? Well, our measures are kind of broad. We tend to base outcome or improvement on a lowering of a score that measures depression or anxiety or psychotic symptoms. These are administered generally by clinicians or clinical raters, and they're not precise. They're not precise at the level of a fasting blood sugar or hemoglobin A1C, which are tests for diabetes or prediabetes, or blood pressure in terms of actually measuring systolic or diastolic blood pressure. So we have a softness. That softness is problematic because the variance in rating individuals can be greater than the drug effect seen.
Oh, that's interesting. So we do our best to kind of structure and standardize our interviews.
Yes, there's usually training, and there are companies that do it. And there are companies that, in fact, do centralized ratings where they just take it out of the local site's hands or whatever. These help, but they don't help in a consistent or uniform way. And so we still have drug trial failures. In fact, we've had two very prominent ones. Recently, one for looking at cognition in schizophrenia, and one for refractory depression, where we had some hope that we would get some drugs that would be effective into the market.
So just say a word about that. How is it determined that a drug trial is a failure? And that's usually after a whole lot of investment of money and way down the road. Is that right?
So there are basically 4 phases of drug development. The first phase is take a compound and to do safety in humans after you've done safety and biological or pharmacologic effect in lower animals. And so that's called phase 1. That can be done usually in healthy volunteers. It can be done in a subject population. You can look for safety in a population, and also you're looking at whether the drug's absorbed, do they get a blood level, etc. In phase 2, we're doing a clinical trial where we're kind of testing out varying dosages. And in phase 3, that becomes what we call the pivotal phase, where companies need to declare what the primary outcome is going to be and negotiate that with the agency, and then generally do a randomized controlled trial. Right. Now, you can do a randomized controlled trial against an existing drug, and you could try to beat that drug. That's often very tricky. So what most companies do is to do a randomized controlled trial against an inactive placebo. And it could be a sugar pill or whatever. And that then becomes the test, and the company declares that, let's say, a 50% reduction in a rating scale for depression, Montgomery-Åsberg or Hamilton Depression Rating Scale. And the difference between active and placebo in attaining a 50% reduction over a period of time, usually 6 or 8 weeks, that would be a positive trial. If they use on a primary scale, they may use a secondary scale as well. But let's say the drug separates on the secondary, but doesn't make on the primary because there are the nuances and differences amongst the scale. Well, that wouldn't count, generally speaking. Yeah. So companies need to have 2 positive trials. Partly the positive trials are going to depend on the effect size, and the effect size and the statistical significance will also depend on the size of the trial. So you can do a larger trial with a smaller effect, you may get significance. In psychiatry, we've tended to not do the 8,000, 10,000 patient studies that maybe some parts of medicine. They tend to be smaller studies, and the effects aren't that large, so that, in fact, the likelihood of showing statistical significance is lower. And so we've had some reasonably sized trials even fail. Now, there are maybe other reasons besides the variability in the ratings. There's also a high placebo response in our disorders. Being nice to patients is not only heartwarming, it's also quite supportive. So patients come in and you're doing a depression trial, you're spending an hour with them, you're seeing them, you're getting rated, they're chatting with people.
And I'm interrupting just to say that many people think about a placebo as something that is totally neutral and has no effect at all.
Not.
And when you have a regular appointment to go in and you're taking a pill that you don't know whether it's active or not, you're getting a lot of attention, and this would be comparable to what we would call supportive therapy.
Correct. And as Giancarlo Zubietto, who's on our symposium tomorrow, has nicely shown, it's also quite biologic. You can block the placebo response by giving an antagonist for the opioid receptor.
Yeah, he's going to talk about that tomorrow, actually, at the symposium.
And it's beautiful work. But it shows there's a biological aspect to placebo. So, placebo is not a non-treatment. Placebo is not the patient staying at home and does a natural follow-up. And that's a real problem for us. So what happens is we have a non-specific response, and how we deal with it, we've thought, gee, these drugs are really powerful and we can separate. Now, having said that, and people may think, oh, this is just the problem of psychiatry, we're starting to see placebo responses in disorders that are thought to have been more severe and less likely to have placebo response. Schizophrenia, cognition and cognitive deficit in schizophrenia most recently. But even in neurological diseases, you're seeing placebo responses or nonspecific responses in dementia and in multiple sclerosis, etc. So to the extent that we have softer kinds of signs that we look for and measures, we have problems, particularly in neuropsychiatric disorders, where emotion plays an important role in how the patient feels.
Yeah. Well, and there's another factor in here that we haven't explicitly mentioned, and that is money. Because it costs a lot of money for a pharmaceutical company to go through all these steps. And actually, the amount that it costs just to get to the end of the line for a single trial of a new medication is phenomenal.
Over $1 billion.
Over $1 billion.
Well, particularly when you consider your cost of your failed drugs that you have to pay for. You often have to pay for failures even within a class before you can get the one that's effective, well tolerated, easily delivered, etc. So drug development is very, very expensive. And because of that, companies, in fact, will go to where they have a higher likelihood of succeeding. And we have had lots of drugs since 1988 with the advent of the SSRIs, with fluoxetine being the first, Prozac being the original brand name. And we've had lots of SSRI, SNRI follow-ups, and we've had lots of atypical antipsychotics, starting with risperidone and clozapine and olanzapine, etc. So we've had drugs. But what's unfortunately happened, though, is that we have those drugs, we have lots of patients who can be helped, but not all patients are helped by these drugs. So you still are left with 15 to 30% of any disorder who are not going to respond to a first line or a combination treatment strategy. So we need to have drugs.
New choices. New choices.
And if, in fact, investment moves away, which it has to some extent, and it was moving away, then we had a bit of a flurry of a number of companies that were developing some interesting products, and several of those have recently kind of failed because of high placebo responses. And so, we may again now see a further retrenchment from investment in the field. And I think this worries me as I get older, and because we need to have new drugs, not for the patients, but also for the treaters. Sure. You can't have a field that doesn't have new therapeutics. It's kind of potentially demoralizing.
Yeah, it's going to go flat. We never have enough time for these discussions, so we're going to have to stop. But is there a best shot game plan that you think we could try to mount that would make a difference in terms of getting some momentum?
There are some drugs that are close to separating, if you will, from placebo, or separate in some studies, not others. And it may be that having the field look over the data in a more comprehensive way and developing a more flexible approach. I think that's the case with a recent drug that failed, an interesting drug for refractory depression, where there are some positive data, and they have another study, and if they can put those together. So that's one, that if we can start to think a little bit more. I think obviously we're going to have better diagnoses, but better biologic diagnoses. We have to have biomarkers. And there the field, it's another discussion, and if you invite me back next year or 2 years, we'll talk about it.
We'll do it, we'll do it. And we talked a little about that when I was just talking moments ago with Dr. Zubieta, because he's looking at that kind of imaging effort.
Biomarker. And I think that there are probably more better leads than we think. Our field has, I think, often overly critical, overly dismissive, and not flexible enough in terms of our own thinking. I'll give you an example. If you look at the effect size for aspirin for preventing heart attacks, and a lot of people take them, right?
Yeah.
Take aspirin, take a baby aspirin or full aspirin.
Sure.
It's very low, has very low effect size. Yeah, people don't have great doubts about it, right? A lot of people use it. you know, if we have an antidepressant that has an effect size of 0.2, 0.3, we have critics who, inside and outside who kind of dismiss it.
Right.
You know, so we need to develop, I think, a kind of a more flexible and a more open way of looking at opportunities, because to close those off unduly, prematurely, probably is not helping us in terms of coming up with markers that could be better targets.
Okay. Well, you're one of the champions of this important agenda, and I think we have to just stay tuned because it's tremendously important for us all. We're out of time at this point. We have to stop, but it's been great to chat about this.
Great being in Houston.
Yeah.
Appreciate the invitation.
Good, and we look forward to your joining us and hearing from you tomorrow at the symposium.
I'm looking forward to it myself.
Good.
Thanks.
And thank you all for joining us again, and we'll see you next time.